Muy buenos días. Bienvenidos.
Morning and welcome to the International Conference of Mutualism 2019, organized by the Alliance of Mutuals of America and sponsored by the Union of Mutuals of Uruguay, declared of touristic interest by the Ministry of Tourism of Uruguay. We will read the greetings of the authorities who could not attend. President of the International Association, Dr. Juan Pablo Uribe, President of the Senate and the General Assembly, Mrs. Lucia Topolansky, Senator of the Republic, Ruben Martinez Huelmo, National Representative Jose Quintín Olano Llano, Director of MEC Centers, Brenda Rondán, Director of the Social Welfare Bank, the candidate to the presidency of the Republic. We thank the presence of national authorities, of local and international mutuals, and the ambassador of Colombia and Uruguay, Dr. Fernando San Clemente Alzati. We also thank the presidents of the UMU entities for their presence, Mr. Gerardo García Real, Dr. José María Cancela, interim president of Casa de Galicia, Mr. Juan Salgado, president of CUTSA Seguros, and the representative of the chairman of the Automóvil Club del Uruguay. We will first listen to Elisa Carolina Torrenegra, presidente of the AMA. A very good morning to everyone. We know that this conference is being live streamed internationally. Ladies and gentlemen, this morning we are joined by a common way of thinking and acting, a way of living around something called mutualism, that the person who carries out professional practice in a mutual environment lives and acts differently. Mutualism is a way of carrying out a life around serving people, human beings, friends, associates, the members in the affiliates in the country who allow us to give them different services, and this makes a difference. In the world, this has been happening in such a way that we are already a part of a whole social and solidarity economy in the world, with huge contributions in terms of the powers: political power, economic power, social power. In the world, this has already been happening in an important manner, especially in the countries where the governments have started supporting solidarity economy and social economy, which is contributed between 5 and 10% of the GDP of the countries receiving this support, through all the different organizations, mutual cooperatives, organizations of formal employees, fair trade organization, ethical banks, associations of producers. And what is important is that we generate a large number of employments, of jobs that are not being sufficiently considered in the European economy. We are contributing over 2.8% of the jobs through these organizations. These organizations are also more resistant throughout their lives than traditional economy companies. Traditional economic companies, after 10 years, they only 20% survive. In our case, it's 40% after 10 years of the foundation. And when there are crises, the organizations of the solidarity and social economy are the ones who help people. Because we work for people, the UN Assembly and all the countries have established the Sustainable Development Goals, which are 17, and they are on the screen now. But specifically, the interagency group of the social and solidarity economy in the world established that from those 7 objectives of sustainable goals were being part of the mutual and social and solidarity economy work. And we are talking about the transition from informal jobs to decent jobs, the ecologization of economy and society, so local economic development, welfare and empowerment of women, the food security coverage, universal coverage of health, and transforming finances. We are today meeting around a topic that in most of the countries has been achieved, universal coverage of health. But it's not just that, it is about giving good services with quality. In Estonia, we visited in June 19 of 2018, and from the UMU an idea came: why don't we have a specific mutual conference about the quality of the services provided? Why not? And that is why we are here, because the quality of services is what we need to be the differentiating factor for our members, of the people who receive our services. And that is why we have invited international figures to come to this conference to bring the best European experiences. We have participants from Europe that are coming to give different talks, and we hope that during these 2 days of work we will be able to contribute another grain of sand to the welfare of our people, which is our responsibility. So welcome to this conference, the International Conference of Mutuals in Uruguay. It's a conference that is focused on health care. Welcome, everybody. In addition to the excuses given by the Master of Ceremonies, we would like to make a recognition to the President of the Republic, Dr. Tabaré Vázquez, who had confirmed his attendance, and we will read a letter that will be given to the Minister of Health, who is here with us, and that reads as follows. Mr. President of the Republic, Dr. Tabaré Vázquez. Dear Sir, in the framework of the first edition of the International Conference of Mutuals, organized by the Alliance of Mutuals of America with the sponsor of the Union of Mutuals of Uruguay, we wish to make our highest recognition to you because of your fight for health and control of non-communicable diseases. AMA is a regional organization that is part of the Mutuals of Americas that for the strengthening of the mutual principles, and its ultimate aim is to protect human beings in all the stages of their lives. We feel, therefore, very deeply involved in all those initiatives that aim to achieve the welfare of the inhabitants of our countries. Your constant defense of public health and your bravery to confront adversaries are an inspiration. As Latin Americans, we are proud to have such an important leader in the promotion of health who has gone beyond borders to become examples in the international arena. We know that because of your track record, you have received a lot of distinctions. And today, since we are honored to have you here, we would like to take the opportunity to express our congratulations for your achievements and our gratefulness for your work as a president, as a doctor, and as a committed individual, and our encouragement so that you continue in that path. This is a very humble gift for your contribution to the public health of the Americas. Before we finish, we give you our best estimation and wishes. Thank you very much. We thank the presence of the Minister of Public Health, Dr. Jorge Basso, at the table, and we would like to invite Elisa Torrenegra to hand out the recognition for the President of the Republic, Dr. Tabaré Vázquez. And now we invite Dr. Gerardo García de Real, Dr. Juan Salgado, Dr. Michel Mocash, and the Minister of Public Health will stay. And we are calling Mr. Juan Pivetta to become part of the panel on the stage. This International Conference of Mutuals is organized by the Alliance of Mutuals of America and sponsored by the Union of Mutuals of Uruguay. Thank you very much. Thank you. So we will start with the topic of Table 1, measurement of health services and funding, which will have 3 panels. We present the first panel of Table 1, which is moderated by Dr. José Cancela, Minister of Public Health of Uruguay, Dr. Jorge Basso, and Mr. Juan Pivetta, the President of the Argentinian Mutual Union. So we give the floor to the Minister of Public Health, and we will listen to him now. Good morning to everyone. First of all, our greetings to the organizers of this international conference, which makes us very proud because there's a long history in our country of mutual work, mutualism, cooperatives, all these actions that make our society have a long history of solidarity, and especially in the good management of the services, because we are talking about a very important number of institutions in our country that have a very long vocation of good management. President of the Republic, who could not be here today, asked me to convey to you his interest for these initiatives to persist in time, and he really welcomes the idea of holding this conference in our country, and he wants to welcome all the foreign delegations and also sends greetings to all the organizations in our country because this is a work of a lot of Uruguayans, a lot of managers and administrators of public goods that show how well things can be done in our country. Concerning the topic that brings us here today, as you know, the issue of quality of care, and especially in the framework of the health reform that our country has been developing in the last 11 years, is a very important topic, and everybody knows that when you start achieving some objectives, especially when they are related to universal coverage and accessibility, there is a challenge of controlling the quality of care, and this is a key aspect for any reform process, like the one we are developing in our country, and we have been able to achieve in these years to solve problems that are substantial for mankind. You know that most of the health reforms in the world have failed. Some have come and gone, and others are being questioned constantly, because health, of course, is very complex, and when you do things well, demand will increase and there will be new needs, and even the concept of quality of care, you know that it's a very subjective issue that is determined historically. It's not an easy definition, and particularly at the time of identifying indicators, there is a lot of questions about their validity. But what is clear is that there is, of course, it is a fundamental responsibility to measure, to assess, and to be accountable. And in our country, of course, there is a special concern about it. And we have created an agency for AGESIC, which is related to the presidency of the Republic and has the role of following up on public policies, especially those that depend from public funds. And we have a system that is based on a fund that manages public funds. So it is very important to evaluate the quality of care. I would like to mention that in these 11 years, we have been able to have universal coverage and accessibility. And for those of you who are not Uruguayan, a reference that seems very clear is that we have insurance system through which the population contributes with part of their income, 4 or 5%, and companies a corporate contribution of 4 or 5% is supplemented by public funds. In 2018, this contribution of public revenue stopped growing because we were coming from an accumulation process and incorporation of collectives. And we have a very good news that general revenue contributions have stopped growing and they have stabilized. So this volume of money is related precisely to paying to the providers, to the 43 health providers in our country for 3.5 million inhabitants. You will not find, you can search, but you will not find a health system that for 3.5 million inhabitants has 43 providers. You will not find it. And this refers to the complexity of the governance. And this health system pays a per capita for each one of the users. And there are variations, of course, throughout the healthcare process. And this is adjusted by census. But it's a per capita of $80, which in Uruguay is equivalent of renting a garage space in the residential urban areas of our country. With $80, we are financing integrated healthcare for the population, and 8 of those $80 go towards the national fund health fund, which is an insurance for high price services. So we have the intention of obtaining the biggest performance, the best yield from these resources, and we are making a big effort to stimulate a good, healthy competition among these 43 providers. There's one public provider and the rest are private providers, and the idea, because there are no competition concerning price because this is regulated. Price is regulated. This is a variable concept and it has been changing but there are historical references that talk about structures, processes, and results. And we have an installed capacity that is very powerful. We have a health map that shows that we have resources and materials that even are oversized. We have a big challenge of the capacity that we have to locate them appropriately in the whole territory of Europe. But we have a huge amount of equipment, and we have a human resources capacity that is also concentrated in the urban areas, but it's also powerful and is adequate from the point of view of qualifications. And we have cutting-edge technologies in all the providers who have made an effort, even with some funding from the state, from the government, to facilitate suitable equipment infrastructure. And all of this is necessary, but it's not enough. And the big challenge here, when you talk about quality, is to work very strongly on those aspects that are related to processes, especially microprocesses, where the relation with the users, who are the ones who are reached by what brings us here today, to try to improve their quality of care. And of course we have some indicators that tell us that things are doing quite well. We have traditional indicators. According to traditional indicators, we are among the first places in Latin America. So these traditional health indicators show a good performance concerning some aspects related to the opinion of users. We are doing surveys that mention each of the 43 providers show a satisfactory level. In over 80% there is satisfaction. So the health issue is not a debate currently, because there is a satisfaction that, of course, doesn't mean that we don't need to continue improving, but we don't have a problem of bad opinion of the current services, and these services have become mandatory. They are not open to the decision of the providers. They are mandatory, and they are being updated and improved constantly concerning support services. And this tells us that we have a very strongly installed system with challenges for the future, and we wish, through some quality indicators, to achieve a healthy competition between the providers. And I would like to mention two topics that concern us and that are being institutionalized in relation to a strategic view of quality care. One has to do with the primary level of care, where a good part of the results concerning health are obtained. We have an overuse of specialist technologies and equipment, and we think, according to the existing international experience, that we have to use the capacities of the primary level of care, with the team working at the territorial level and networks to be able to supplement the services of the providers to make the expenses more efficient. We have made a call, and now we have a second call for the presentation of good practices in the primary level of care. We have identified some good practices, and we wish to stimulate those institutions that have created successful techniques in this topic.
We also have a low birth rate, as almost 50% of the countries in the world. We also have a decreasing birth rate. It is below the exchange rate. So this decreased rate means that although we do have a continuing policy in this regard, we are concerned about having good pregnancy checkups, also promoting institutionalized births and perinatal care. This has been of special concern to public and private providers because they have tried to focus their health funding on having excellent maternity services. Currently, we have a special motivation because we would like to encourage the institutions that have excellent maternity services. This means in infrastructure, process and results as well. And we would like to imitate their good practices. We are anticipating an accreditation system that the country will need to face. We need to create the necessary institutions. And we need to remember that this is like a preliminary process that comes before an accreditation process regarding healthcare structures, which are regulated, of course, by the health authorities. Another very important topic is that of being motivated to change, especially regarding public administrators. They actually work with public revenues. It is a large percentage of the GDP. So from the institutions, we face a major challenge when it comes to improving practices and procedures in order to promote change in healthcare providers and also continuous improvement. We have had some very good experiences. We're working together with the academia, and we are trying to work from an institutional and organizational perspective so that we can strongly focus on improving microprocesses and on working on user satisfaction by using resources rationally. When we talk about improving healthcare, it also has to do with improving the quality of spending. Both things, quality of care and of spending, are important within our powers because we have to defend public revenues in order to maximize the benefits in the healthcare system. We would like to consolidate this national integrated system. We control healthcare costs. We supervise them. We also have indicators that measure and evaluate how costs are managed. And there's something I need to say. This is a work meeting, and I'm sure this will have no public consequences. But I need to say that we do have a great challenge ahead of us. We need to improve our spending. So we need to achieve better results with the public monies that we are administering. So we do have very good experiences. For instance, in some areas of the country, we have structures that are not rationally used. We need to promote the complementarity of services among institutions. We need better efficacy and efficiency in the use of resources, especially when we are running a public system that is funded by the population and that aims to improve some of these indicators. Finally, I would like to say that Uruguay never before had, at government level or supervision level, an information system as it has nowadays. And this is essential nowadays if you have management tasks. We now have the clinical, record, health record, and providers share them. This will allow us to work. We will no longer have clinical records in paper, which is the case in some institutions. Most of all, we will have data in order to quantify our efficiency, and we will be able to know how we can encourage good practices, and we can see how we can make the most of the public funds that we are sending to institutions. Also regarding financial controls through the National Information System, the study of healthcare costs, also audited balance sheets, and we supervise the 43 healthcare providers as part of our institutional responsibilities. This makes sense, finally, if all the users, and especially the most vulnerable ones, feel that they have a social protection system in the healthcare system, and the system caters to their needs. Uruguayans have a longer life expectancy, and this also brings chronic pathologies, so they are incurable. But we need to help people. We need to treat people as well, because they won't be cured. And this poses a huge challenge regarding the funding of that type of care, because these people need, we need to follow up on special indicators. We need to be moderately sure that we are on the right path, that public funds are being used to improve the quality of care. Thank you. Thank you, Minister of Public Health of Uruguay, for your presence. Mr. Jorge Vaso, we would like to thank you for your words, and we would like to present you with a present.
Bueno, le damos las gracias nuevamente.
Well, thank you again to the Minister. This has been quite a nice updated account of the overview of health in Uruguay and of our perspectives as well, our outlook for the future if we work in health. And we need to continue measuring the quality of healthcare. I believe this is one of the main topics that we are facing when we manage health institutions. In this same subject and on a different topic, we will hear Mr. Juan Piveta, who visits us from Argentina. He has a master's degree in social security information systems. He's a general agronomist. He founded the Humberto Volando Foundation together with other members. He's a president of Federada as of 2010, and he's a member of the executive board and coordinator of the Commission of Health of the Argentinian Confederation of Mutuals. He has many other positions, but we don't have time, so please, Juan, you have the floor. Thank you. First, I would like to thank the AMA and UMU authorities for inviting me here today. This is very important for the Confederation for Mutualism for Argentina. I'm very proud to be here today. Honestly, it's great to be sharing this panel with the Minister of Health of Uruguay. From Argentina, for those of us who work in the healthcare system, we really welcome and we admire the health reform and the transformation of the health system in Uruguay. To some extent, those of us who believe that we need to coordinate and integrate some other aspects, Uruguay is a model to follow, and that's what we believe in Argentina. Very briefly, I will tell you about maybe the opposite. It's the opposite of a comprehensive or integral system. I will tell you briefly about the Argentinian system, sources of funding, elements, etc. Very briefly. It will be very difficult for you to understand the whole thing. And then I will be talking about the organization of mutual organizations and cooperatives, and this is my strong point. Actually, our federation is completing a survey now on healthcare mutuals. We have a social economy, and we do have updated data regarding the presence, the number of services, number of people reached by mutualism, health mutualism and cooperativism in Argentina. But before that, I will give you an overview of the health system in Argentina. Slide 1. The Argentinian health system is formed by 3 large subsystems. The public subsystem, fully public. Maybe the figures are not completely accurate, but we have around 44 million people, and the public system reaches 15 million people in Argentina. The health is covered by the public system. How is it formed? Basically, nationally, the nation has quite a strong impact. Why? Because Argentina is a federal country. Each province is autonomous. It has its own health policy, its own minister, health secretary, etc. And this makes the whole system very complex, and the Ministry of Health maybe does not have so much power because each province has their own powers. But Argentina has over 2,000 municipalities, so healthcare in municipalities has mainly to do with primary care, and each municipality has its own strategy. Many times they coordinate their work with the provinces, but not always. So around 15 million people in Argentina all attend the public subsystem. The public subsystem, we'll see where it gets its funds from. The other subsystem has to do with social security, and it has the Bismarck logics, the formal worker and contributions made from this work. And here we have the armed forces, universities, also different organizations. 7 million people belong to this system. We also have the PAMI that includes retirees and pensioners, almost 5 million people reached by this system, and also the national organizations or obras sociales in Spanish that usually come from some kind of union. In Argentina, there are around 280 unions, so 280 obras sociales. This is something quite amazing that we have managed to do over time. Around 14 million people are covered by an obra social. And 3, we have the private subsystem, where we have mutual healthcare organizations, cooperatives, etc. Around 2 million people are covered by this in this subsystem, a private subsystem. However, actually, in Argentina, there are around 5 to 6 million people who attend healthcare services provided by a cooperative or obra social. The thing is that, or another private subsystem, because there is a deregulation system whereby prepaid organizations also work. Therefore, the private subsystem provides healthcare to around 6 million people, and part of those people come from obras sociales. I will be very quick, and this is a lot more complex. but actually you don't need to understand all this. I would like to say a few things that you should remember that have to do with what the minister was saying regarding spending on capitation. We have $330 in the public system. For obras sociales in the provinces, in the second column in blue, we have 707. For retirees, we have, for PAMI, $1,082 per person per year. In obras sociales, we have 646, and we do not have accurate data for private insurance services. Well, where are services provided? Public health through hospitals and other institutions. In obras sociales, through private clinics and private professionals. PAMI, we have private clinics, own hospitals, professional hospitals. Obras sociales, for unions, they have their own professionals. They have their own infrastructure that also includes social security and some private professionals as well, private clinics, hospitals, etc. As we do not have much time, I will not give you more details, but we can see many ways in which healthcare is provided. Just a few significant data. Argentina, have a look at the figure at the end, 10% of its GDP, which is over $500 million a year to health. This means that we do have a problem. How is this money spent? It's spent on the system I was showing before, which is so fragmented. Therefore, different funding forms are coexisting. I forgot to mention this. It has to do with the source of the funds for each subsystem. The public subsystem depends on tax, provincial municipal taxes, general revenues, obras sociales contributions of workers, also the provincial treasury, also volunteers and co-payments, what out-of-pocket expenses, PAMI through the connection between workers and retirees, also obras sociales, work through the contributions of workers or the contributions paid by employers. And private insurance, the private insurance system includes out-of-pocket payments. This makes the system very complex because it's fully segmented and fragmented. It has different segments, and there is a lot of fragmentation within each segment. There are different types of funding, different providers, and this makes the system very complex. Still, 10% of the GDP is invested in health, which is quite a high figure.
This is a general view, and the coexistence of these systems generates a fragmentation, and it is translated into some inequitable indicators in Argentina concerning healthcare access, and I will give some data that are significant. For example, in federal capital, there is a doctor every 94 inhabitants, but in Formosa province, there's one doctor every 700 inhabitants. So this is a consequence of the lack of integration of a single health system. Or we have 300 people per bed in Formosa, for example. And I'm using this province because it has very bad indicators in some aspects, and there are some health indicators such as child or maternal mortality In Buenos Aires, we have 6.4 per thousand, and in Chaco, it's almost 11. It's 11, so almost double. So 1.9 maternal mortality in Buenos Aires and 7.3 in El Chaco. So there are different priorities that are given by the provinces to the health topic. Very quickly, now I will go to some specific data of mutuals in Argentina and cooperatives, because as you know, just like in Uruguay, mutual system has a very rich history in our countries. INAE, the National Institute of Social Economy, President Marcelo Cono proposed to do a national census of health cooperatives because the sector didn't know how many we were, what was the quality of our services. So in this framework, we have reached 86% of execution of the census, and we have almost definitive numbers. So there is a mutual cooperative in each of the 23 provinces and the federal capital in Argentina. We have surveyed 3,036 entities. This is a list that we have in our entity, and the polls were done in 317 entities that are providing some kind of health service in Argentina. Out of those 37 entities concerning associates, so members, there's over 1.8 million members associated to mutuals. It is a bit different with cooperatives, and there are 1,869,000 those that are covered by a cooperative of health services. So it speaks very clearly where this person is when we saw the description of the subsystems, because we're talking about 3.5 million people. And I will go back very quickly to show you where, in what part of the health subsystem they are found. So there's a big part that is a private subsystem. A part is supplemented with social security, and the other one with the public system. The mutual and cooperative segment is the only one that supplements with everything that is in all the subsystems. Obviously in the private subsystem, but it also supplements with national obras sociales, because there are people who have the coverage of a mutual, although they have, like PAMI, for example, and it has a very deficient service, so it is supplemented through this system, and it improves access and equality of the service, and it also supplements a public subsystem. And that represents all the people in the mutual and cooperative system. So it's also important to know where they're located, what is the scope of their work. And we have only 57.9% are in all the country. Then some are regional. So that's 9.9% that they have one province or more than one, but they are not national. There's a 24% which are only in one province, and the large majority, 58%, this is only in one locality and an area of influence. They are very territorialized, so they understand the needs of the population in those territories. The origin or dependency of the entity, there's this union related in, I don't know, the rest of the countries, but in Argentina, mutualism was developed before trade unions, so it is related to the different trades and then to the unions, but many of them have a lot of trade union dependency. Others are corporate, the communities, Italian, Spanish, French. Also historically, in part, it's also the case of Uruguay. There are lots of mutuals and cooperatives that are related to the community and sectors and others. Concerning the structure, and this is important when we think about access, and we think about a universal health system and coverage and complementation between social security and social economy, and I'm totally convinced that between the government and the social economy there can be a perfect complementation to achieve universal coverage. In the case of own infrastructure, from the primary healthcare, ambulatory offices, small labs, biochemical labs, to high complexity that as in many community hospitals. In this framework, we see that half of the entities only manage resources and can't make outsource to the private sector, but others have their own infrastructure and some others that do a complementation. And there's a lot of capacity available in our sector that is owned by our sector. Because I'm running out of time, I will just do this very quickly. The types of coverage that they feature, from integrated coverage to dentistry or emergencies, pharmacy. There are lots of mutuals that give services related to medicines, dentistry, laboratories. There are some that have hospitalization, but these are mostly community hospitals and health, mental health, of course, and orthopedic. And I will not delve into these aspects, but what is important in ending is to share this data with you, which is very fresh about our sector, and this is work that is being done by the sector itself, that the government commissioned the sector to do it, and we have reached the conclusion that there is a history, there's a very important potential currently in the mutual sector when countries are all thinking about universal coverage for our population. When we think about the policies, many times we don't consider the reality of the sector and how it is already structured, and the potential of mutualism in Argentina is very great. It should be coordinated, articulated. Uruguay is an example that it is possible to articulate and have an integrated system. In Chile, President Piñera is launching a reform of the health system, and Argentina also needs it because it starts to fail in achieving the objective of the health system concerning access to quality, equitative care, and of course providing financial protection, where the costs of health are constantly increasing and the value of medicines in Argentina is increasing terribly. We have treatments of $900,000 per year, when in some cases there is no scientific evidence that these treatments would cure people who have these diseases. So from the ministry, we also call for an integration of the system to make it more efficient and reach more people and achieve universal health coverage. Thank you very much. So this has updated us about the Argentinian health system, which for us is not so well known. And even though we are tight with time, I would like to ask the audience if you have any questions for the minister or Mr. Pivetta. I would dare to ask the minister. He spoke about the qualification system for the future for the institutions. We know that qualification systems with professionals take some time, and we would like to know about this issue, whether it will be connected with primary care, good practices of primary care, what aspects will be related to the accreditation system for institutions. We were saying earlier that the key is for users when they have to decide the provider they're going to use. They need enough information, quality indicators and data for decision making. And the ministry so far has a web page with information about some aspects, traditional aspects connected with wait times and the costs of co-payments when they are. And we were thinking about including a column then about institutions who appeared in the call of the Ministry of Health to show good practices of primary care and give them. And so we would like to identify them in that information that is available in the webpage for the successful experiences that should be emulated, especially in relation to change management. There are no magic formulas, but those things that we know that are working, it's a way to motivate the service providers to make improvements. The increase of capitation stimulates these efforts, and it has helped achieve some good processes concerning users and not just patients. So this has worked for high blood pressure and pregnancy checkups and non-communicable diseases. But another aspect that we thought was important is a gratification of being identified in a web page as a good practices provider before accreditation. And in all this process, from the institutional point of view, this will take some time, but we think it is very important, as we said earlier, that the institutions have been very highly involved, and I'm mentioning it here because they are mostly present here, involving the users and the workers in the change processes. You cannot achieve better results without a strong involvement of the workers and users. I know it is a complex task, but it's indispensable. It is impossible in a service like healthcare, which depends so much from human aspects, to achieve good improvements without the involvement of its workers. And the managers and decision makers at the institutions can involve and dialogue, interact with medical and non-medical workers and users, promote the organizations of users, because it's the only way to obtain changes, and the changes in continuous improvement are very demanding in terms of working with workers and users. We want to stimulate users when they make decisions of service providers to have quality information, documented information that will allow them to make a decision about the provider that they will use for their own health and that of their family. So there will be an accreditation process, and this good practices system is an advance of that. So now we will give a token appreciation to Mr. Juan Pivetta, the president of the Health Mutuals of Argentina, the Union of Health Mutuals of Argentina. So we now invite you to the break, and we will be back in half an hour to continue with the second panel of Topic 1, Measurement of Quality and Funding. We remind you that with the information from each of the participants of the conference, there will be an email that will be sent with the certificate of attendance. So it is very important to fill the spreadsheet with your data. Thank you very much.
Y ahora sí presentamos al segundo panel de la mesa 1.
Now we begin the second panel of Table 1, Quality Measurement and Quality Funding, moderated by Dr. María José Cancela, UMU Treasurer. Mr. Matthias Nieland, Department of Studies and Representation of the National Confederation of Mutuals from Belgium. Dr. Rosana Gambogi, Technical Medical Director of the National Resources Fund of Uruguay, Dr. Federico Preve, representative of the Medical Union of Uruguay, and Dr. Julio Martínez, General Manager of Asociación Española. We would now like to give the floor to Mr. Matthias Nieland, who is visiting from Belgium. He will be talking about quality of care, evaluation, and funding. Matthias has a master's degree in management and health policy awarded by the University of Belgium. He is a specialist in sociology. He's a member of the Socialist Mutualities from Belgium. And he also works in different groups at a national level. He has published different studies on health management and policies. And we are very much interested in the talk he will be giving in a minute. Thank you. Before I begin, I would like to thank the AMA and the UMU. It's an honor for me to be here, to have been invited from Belgium. I would like to talk about the quality of healthcare. So, do you speak Spanish? Well, Spanish clearly is not my mother tongue, so I will do my best. And also, I would like to say that when we talk about quality of care, we need to talk about the same thing. This is why I would like to begin with this after the introduction. I will say, what do we understand when we say quality? Then I will talk about quality as a right or a duty. Third, quality indicators. Should we publish them or not? Which are the advantages and disadvantages? Then I will talk about the role of mutuals in the future and about the role of mutuals today. And then I will draw some conclusions. So what do we understand by quality? I can imagine that there are doctors here in the room. When we talk about quality, in most things, we talk about the classic triangle. Quality is a combination of structure, how it's organized, the process as well, what we do in order to provide the better quality possible, and what is most important to the patient is the result. Does the patient feel better or not? However, this triangle concept is not enough for us. We have also heard before that it's important to consider as a quality care aspect. We need to remember accessibility given financial costs and also given distances. Each person in a country needs to have easy access to a health institution or to a medical doctor. And those objectives of the triangle and accessibility as well can be measured as objectives. We can measure them and then we can say if the quality of care is good, bad, low quality, high quality, etc. But there's something else which is not so easy to measure, which is the wishes, patients' wishes and subjective experiences. For instance, if I want to go to a hospital, I'm very happy, and I say, I've been really well treated, but I don't want to go to a hospital, for instance, to another hospital because my dad died there. And that is a subjective experience. It's not objective, and it's very difficult to measure. When I talk about quality, then I include all this. Is quality a right or a duty? It seems to be an easy question. Okay, let's say yes, quality is a right of patients and that physicians and providers should cater to. But it's not that easy because nowadays we are going from paternalistic health to a health system where the patient is seen as the physician's partner, let's say. Why partner? If they are partners, then patients need to have information about healthcare, if it's good or not. So it is a right, okay, but it is now becoming a patient's duty as well. Why? Because nowadays patients have more and more information about the quality of care. So they will decide, for instance, if they want the best possible care, then they are responsible for looking for this kind of care. We believe we're not very happy with this, where this evolution is going, because quality needs to be a right, yes, but it shouldn't be a duty, because it makes physicians and institutions responsible. But it's different for patients. We believe that quality should not be a patient's responsibility, because nowadays there are patients that do not want to choose. They just trust in physicians or institutions, and that should be possible as well. If we would like to choose, or if we need to choose as patients, and when there is freedom to choose, it is very, very important to have the right information about the healthcare we are looking for. And to do this, we can use quality indicators. Two years ago, we conducted a study with the Socialist Mutual Association. We invited some professors, and we learned that a good indicator should include 3 elements. It should be relevant. If I go to a hospital because I have heart problems, it doesn't really matter if the hospital is the best at dealing with stomach problems. I will further explain this in the upcoming slides. Also, indicators need to be understandable. Patients need to understand them. And the information needs to be new for the patient. If patients have known something for 10 or 15 years, then this information does not have added value. So what is more important? Structure quality indicators, process quality indicators? Yes, they are important, but they're more important to institutions or physicians. However, patients really care about results. If the process is not optimal, but the result is very good, then that's what really matters to patients. And also, another quality indicator is the price. Is it affordable or not? Maybe you have the best quality, but it's impossible. But the patient finds it impossible to pay. Then it doesn't really work. Finally, there are some aspects that can be reflected through figures, but not everything. An example from Belgium, in the north of Belgium, Flanders. We have a website that deals with healthcare quality. They publish some indicators. They work with breast cancer, rectal cancer, patient experience, and indicators about the whole hospital. The aim of the website is to inform professionals and patients, both of them. At the Socialist Mutual Institution, we work on the legibility and relevance of data to patients. We say nothing actually about the data, if they are relevant to the physicians or not. We have observed that they are difficult to understand. The website is nice and everything, but the indicators are difficult to understand if you have no medical experience or no medical interest. The indicators are very complex. I do not know all the details. They are divided into odds ratio, hazard ratio, relative excess risk. Patients in general do not understand this type of language. For instance, regarding breast cancer, I will focus on this example in a minute. There are two different quality indicators. However, as a patient, how do you know how to compare the indicators? Here there are two examples. Breast cancer. This is a list of all the hospitals in Flanders, over 50 hospitals. On the website, we studied the 5-year survival rate for breast cancer patients. The median is fine, 81.3%. However, if, as a patient, I access these data, I will try and find the hospital that gives me the highest chance of survival. So here, the arrow is showing the hospital with the highest survival rate when you suffer from breast cancer. However, if I have breast cancer, do I need surgical surgery to save the breast, or mastectomy, or whatever? If I'm a woman and I want to save my breasts, this is very important for me. So the hospital that has the highest survival rate does not have such a good rate regarding chance of saving the breasts. So what am I going to choose? Survival, chance of survival, or maybe a lower chance of survival? Well, what type of survival do I want? Am I happy with a 70% rate? Do I want 80% rate? So the aim, if I have a percentage of between 50 and 80, then the hospital falls within a normal range. However, as a patient, if I want to save my breasts, maybe I save the 80%. I favor the 80% rate hospitals and not the other ones. We know that this is all very important regarding hand hygiene. No hospital reaches a 100% aim.
Pero bueno, limpiando las manos, entonces.
Okay, so hand hygiene. It's important because it provides us with information regarding germs, but it doesn't say anything about other germs. So you can go to a hospital that has great hand hygiene rates, but maybe they have problems keeping the operating theaters clean, etc. So the Belgian website is a good example. It is compared to the VAR system in football. The idea is fine, but it hasn't been fully implemented. Indicators are relevant. Yes, they are, and they are relevant, but they do not provide me with all the information I need in order to make a decision. Are the data new? Yes and no. Well, but not really, because the data we have just seen go back to 2011. If I want to choose a hospital today, maybe the 2011 data are too old. Can they be understood? Okay. I have reflected them on a way for you to understand, but they are not easy to understand when you read the website. Is a patient informed? We believe the patient is not informed. So it's very easy to criticize things, but what can we do as a mutual institution in order to improve this? So what we would like to do in the future as a socialist mutual institution is the following. We're also partners on the website I was telling you about, but we need more energy in this regard. These are 2011 data, and we believe they are insufficient. And the data are very difficult for the patient to understand. What are we doing nowadays as a mutual? We are developing a tool to help patients. We do not want a tool to push patients into a specific direction that we believe is best. No, we do not want to be paternalistic, but we do want to support patients. We want to translate in a way the website and other types of information on quality so that the information can be understood by the patient and so that patients can make good informed choices.
So we want to create a tool that contains a patient's personal preferences too. In the classic way to talk about health and healthcare is not included, but the patient or the member of a mutual is in charge. Not just the most privileged. The website is not very often visited. It's difficult to understand. I do go into it, but the patients in general don't. That is why we want to give help patients go a little further in making their decisions. It's something additional to the website that we have seen. So what are we preparing? It's an orientation in decision making to choose between different treatments. And I will give an example in the next slide. What is it we want to do? We want to combine scientific knowledge with the patient's preferences. We want to say which are the pros of a decision and which are the disadvantages, to increase knowledge. And it's very important because we say that the doctor and the patient are partners. It's very important for the doctor to be included in this. So we want to stimulate the dialogue between doctors and patients. The example is about breast cancer for women in stages 1 and 2 of breast cancer. There is a possibility to choose between surgery to save the breast or a mastectomy. There are 7 things to be considered. First, we will give facts, data about the interventions to compare them, the survival rate of each one of the surgeries, what is the chance of cancer reappearing in the same breast, and I'm only given 2 examples. There's more information, obviously, but this is general information about facts. And we based it on literature, international papers. The next one, to make it clearer, we will make a comparison On the left-hand side, saving the breast, and the amputation on the right. And what can we see? That it is very easy to see with these drawings that after 5 years, every 87 of 100 women are still alive in both interventions. So if you want to choose survival rate, doesn't matter which one you choose. And then we include the price. I've said room here, but we should say rooms for one person. The price is higher if the option is amputation. These are euros. 500 euros are 400 and some dollars of difference. But if you choose a two-person room, the difference is less than 100 euros. The number of days in the hospital in general is 3 days when you choose saving your breast and 5 days for amputation. But you will also have to add the breast reconstruction, which has a cost too. So that if the patient says, yes, I want to save, or I want the breast, or I want amputation, but if I want to reconstruct the breast, there will be an extra cost, and this will become more expensive. So in this way, we will compare different things of both surgeries. And the difference with other things that we are doing nowadays is that we will make 10 questions to learn about the patient's feelings. Here I have 2 examples. This is the slide. The rule is in Dutch, but it is I disagree, I agree, or I don't have an opinion in the middle. So it's very clear for me. It's very important for me to maintain as much of my breast as it's possible, or maintaining my own breast is not important, and you rate it as a patient. And then we talk about complications, so possible complications after mastectomy, such as an infection, make me anxious, or possible secondary effects of radiation makes me anxious. So they choose among those things, and after those 10 questions as a patient, you will start to have an idea of where your feelings are leading you. And then we ask, after this information and these questions, if you would have to choose today, what operation would you rather have, a mastectomy or saving the breast? And how sure is a patient about this decision? Completely sure, not so sure, not sure at all. And then we make a small quiz. I will not go into it, but to see if the patient has understood the information we have given them. And then there's a summary of all the information. And then we have something to add that is a link to VIP2, and that's a system that we have seen. What hospital does the patient prefer? We will see the distance of the hotel the distance to the hospital. If the hospital is 20 minutes away and there's another one at 2 hours of distance and the quality is similar, it's better to go to the nearest hospital. In Belgium, I don't know what it's like here, but there are some hospitals in Belgium that are recognized as breast clinics. So it's important to know whether the clinic is well known or not. And there are personal reasons, as I explained, that I don't like this hospital, I would like to go to another. We will compare cost. And thus we hope that in the future we will be able to help the patient, and with that information they can go to see their doctor and speak openly about their preferences, because their preference of the patient is maybe saving the breast, but the doctor can say, well, but this is impossible and this is important too. So we are not going to tell the patient what to choose. but we will build an exchange between the doctor and the patient. This is what we wish to do in the future. We are not doing this yet. We are researching it, but now I will speak about things that we are already doing. And these are three things that we are doing in general. They are financial barometers, because for us as mutuals, it's very important for financial access to be for all the patients and not for some groups, but for all the 11 million inhabitants of Belgium should have it. We also do member questionnaires, and we do volume studies. The IMA and the IMA Atlas. It's the intermutual agency of Belgium, all the mutuals of Belgium together. In the financial barometers, what do? The mutualities own a lot of financial data. We know everything about the patients. And financial data is easier to exploit in comparison with quality indicators, because these are facts that don't have to be interpreted. You just go to the price, and the price is a price. And it's also easier to interpret for members. It's easy for them to say, this is more expensive, this is not so expensive. Then it's easier than saying the quality is good everywhere, but there are smaller differences. I have several examples that I will show, but the most important thing we do is the hospital barometer. We research patient cost every year. For over 10 years we've been doing it. And we see there which are the additional costs for the patient that are not paid by the mutuality, how much the hospitalization costs, how long it lasts, and we can see it through time. And in Belgium, I think that it's the same in every country, this is becoming more and more expensive. And we have a online tool to compare hospital prices. This is an example, but I can see that the colors are not so clear. But you can see that in Belgium, you can choose an individual room or a double room, and here we can also see about prices. In general, if you go to a hospital with double rooms, you will have to pay 250 euros out of your own pocket, but if you go to a private room, you will have to pay 1,800 euros, and I will explain where the difference comes from. In general, the difference of the general costs is about 50 euros, but the big difference is that there's a supplement for comfort in choosing a private room. I want to be alone, so you have to pay about 50 euros per day. And you can say, well, that's not so bad. But the problem that we have is the 1,000 additional euros for the doctor. In Belgium, if you go to a hospital, the same doctor will work with you in a double room. For example, stents. You have the price, legal price, and you go to a private room, the same doctor, same medical care, etc. And they may ask 3 times more of out-of-pocket expenses. If the government pays the doctor 100 euros and I will pay 50 out-of-pocket, those 150 euros total in a private room, the doctor may ask 3-4 times 150 euros. So for the same operation, they will ask 450 euros. It doesn't make sense, but that's the way it works in Belgium now, and we want to change that. That is why we're doing these studies. Another example is the average cost of a knee replacement in Belgium. And in some hospital, the average cost of materials is 400 euros, more or less, but it can go as high as 700 euros. So there's a very large variability of costs of the materials, and this is paid by the patient. So as a patient, I do want to know the prices of the hospitals. This is an example of the tool we have online of a normal delivery, natural delivery. And you can see on the left the cost in a double room. There's very little difference, 189, 196, 10 euros of difference. But if you go to a private room, the difference will go from 967 to 1,300 euros. So for a berth, there's a $500 difference, a euro difference. So this is a serious problem in Belgium for accessibility. These studies, it's interesting, but do they make a difference? Yes. Every year, we do the same research. Every year, the press is very interested and the whole country is speaking about it. Especially because we have a political agenda. We will have elections in May, and this is a very important issue. I've shown the difference between one bedrooms and double rooms because since 2017, in day hospitalizations, it's been the same cost. Then there are volume studies between mutuals, and for example, in the case of lung cancer, mortality, as is known in international literature, in 60 days is double as high in the centers that do carry out less than 10 surgeries per year. The survival rate per year is significantly lower as well. So in this study, with data of 2013, I think, but we have seen that 93 hospitals in Belgium, out of 93 hospitals, we have researched how many surgeries they carry out every year. 27 centers do less than 10 surgeries, out of which 17 do less than 5. So as a patient, I don't want to go into that hospital. And there are 6 centers that do over 100 surgeries of lung cancer. So I feel a bit more confident in those hospitals. So these figures are accessible for the public, for the general public, through the website. And this makes a difference because after the publication of esophagus cancer, a number of institutions that perform this surgery went from 67 to 55, and it will go down in this next year towards 10. So in the whole of Belgium, we will have 10 centers that can do these surgeries. Other things that we monitor is bariatric surgery, gastrectomy, and pancreatectomy. So this is, because we are mutuals, the role of the patient is very important for us. So about different topics, we create surveys with our members. For example, the resistance to antibiotics, mental health, and we do it to measure the temperature with our members. What is the knowledge they have about these topics? Maybe there's a suggestion of the members, because sometimes they have good ideas that we can transform into policies. What are the expectations of the members towards the government and towards us as a mutual? Is there any chance to improve care, for example, with our experience in COPD? They know that what the possibilities are, if it is care is accessible, and if it's affordable. We also exploit our own data as mutuals together. These are socio-economical data about accessibility, as we have seen, about prevention and use of care and the organization of the care. For example, this is image of a website that shows the number of patients per family doctor we have in Belgium. In the north, we see that there are more patients per doctor than in the south, and this is interesting information if we want to set up new forms of medical care, because it's important to know if it is possible with so many people that you have to look after as a doctor. This slide is quite new. It hasn't been published yet. Seems interesting. It's about dentists' appointments in 2 years, and you can see on the left, here on the left, you can see the families that have the less economic power, and on the right-hand side, the highest. And we think that in a difference of 147% of people who go to the dentist, to see a dentist. So people who have less economic power have a higher chance of dental problems because they don't see a professional. Now we're very close to the election, so it's time for us to make an additional effort for less privileged people. We have a lot of ideas and we do a lot of things, but we have to be honest with the mutualities. Transparency and opening is very important for us, but sometimes we hesitate. Will we publish this or not? Because we have so much data about the behavior of the providers, and there are people in the mutualists that say we shouldn't publish just anyway, and others say we have to be careful because we have to make sure that it is relevant. Let's talk to the doctors first. The patient doesn't need to know, and if it is negligent, you could say, some people say that it's negligent because if you have that information, you should share it with the public. But there's also a right of privacy that in the European Union has changed a lot of things. So you can't publish anything you want. And sometimes we need to be honest here. We are a bit too afraid, because which will be the impact, we don't know. So it's a debate that as a mutuality we have to how far do we go with transparency. Personally, I think that we should go a lot further because it's very important to have everything clear for the patient. And I think I will finish with some conclusions. Quality, we all know, is important, and it can be measured, and what can be measured should be measured. That's a no-brainer. And for us, quality is a right for the patient, but it cannot become an obligation for the patient. So the patient shouldn't have more pressure when they are ill, but they have the right to know. What is very important is that we shouldn't forget aspects that cannot be measured, such as customer preferences, economic accessibilities for us, and I hope for you too, is quality. The mutuals, I'm really sure that mutuals should participate actively in spreading the information. It is very important because quality of the members rely on us, and they will trust us when we speak clearly about medical quality, but always considering the personal emotions of our members. Thank you very much.
Muchas gracias, Dr. Nelen.
Thank you, Dr. Nelen. We'll ask the audience if there are questions later on. Now we go on to the second presentation by Dr. Rosana Gamboshi, Technical Director of the National Medical Resources Fund. She was a technical sub-director of 2 programs. She has been working at the fund since 2011, and in 2018 she was appointed the Technical Medical Director of the National Medical Resources Fund.
Medicina y médico internista. y es asistente.
She's a doctor in medicine and an internist, and she's also a professor at the School of Medicine. She has published different papers on training in ethics, public function, and also, everything related to public servants. Doctor, you have the floor. Thank you for the introduction. Good morning. First of all, I would like to thank the organizing institutions of this Congress, which is very relevant. Thank you for inviting us. And I would like to talk about something that is very important for the National Medical Resources Fund. In the presentation, I will make a brief review of the National Medical Resources Fund, and then I will focus on some strategies implemented by the fund to ensure quality and the financial sustainability of the system. It is important to say from different areas that the fund has been considered a key institution in our health system. Throughout almost 4 decades, it has created knowledge, it has allowed us to develop technology, and most of all, it has allowed for people to access this high technology. Our aim is to improve health conditions. In the almost 40 years of its existence, we can identify 3 stages along the history of the fund. The National Medical Resources Fund was created in 1980 through a decree law at the time. The highly specialized medicine institutes are created in order to provide high complexity treatment. A fund is created which is called the National Medical Resources Fund. In 1993, this decree is eliminated and the fund is established as a public non-state institution. It is specified, its functions are specified as well as its structure and its competencies. As of 2000, the fund practically collapses because its economic feasibility was very frail. We resorted to different consultancy firms, and the final conclusions and recommendations said that the fund was in a critical condition, saying that the fund's model was not enough anymore. Different situations were identified regarding the growth of medical acts. It was very difficult to determine that there were demographic causes behind all this. Also, patients were not selected in the right way. In the first 2 decades of the fund, we basically lacked any type of result evaluation, and all this implies that we need to change the fund's model. In 2002, some of the recommendations begin to be implemented. The fund begins to change its management model. In 2005, which is a very important year to the fund, medication is incorporated in the system, especially costly medication. And as of 2007, we have been working on strategies to control demand through tools that manage the use. And we have also focused on improving quality and care for patients. As of 2007, with the creation of the National Integrated Health System, the fund remains autonomous in its administration. Now we have an $8 fee that is transferred to the fund. It's a single fee. The National Care Plan is created, where the medications and treatments are included, those of the system and those of the fund. And in 2010, a decree sets which are the requirements for medications to be included in the therapeutic list and covered by the fund. we observed the need to conduct different studies of impact, of quality as well, also to have reports provided by a technical advisory committee within the ministry. And also we need to implement the recommendations regarding the therapeutic list of medications to decide if the certain medications would be included or not. Currently, we're working on quality and also on implementing evaluation tools to assess technological tools. And we are now using this multi-criteria model in order to prioritize tools. The fund's mission and vision. I would like to focus on some concepts included here. First of all, efficiency, second, quality, and also economic financial sustainability of the system. Because the fund provides treatment and medications that are very costly to the whole country, actually. Given the number of health technologies recorded and available in the country now, and within the National Health Plan, there is a list, an explicit list of procedures and medications that should be universally covered. Part of them fall within the responsibility of integral providers, and others are the responsibility of the National Medical Resources Fund. These are the services or benefits that the fund provides nowadays within cardiology, trauma medicine, some acts that take place in other countries. Sometimes in Europe there is, we lack the necessary expertise, and also other more recent areas, for example, infertility treatments and the coverage of some devices for heart disease. In the technical area of the fund, here you can find more detailed information regarding the different types of technical coverage and also medications included and technologies included in the fund. Regarding the funding of all these benefits, the fund has evolved and has different funding modalities. Regarding the services provided by highly specialized medicine institutes, funding focuses on payment per medical act through fees agreed on by the Ministry of Economy, Ministry of Health, and the IMAES. Regarding costly medications, the fund has innovated in this regard. Regarding negotiations with industry, we have implemented interesting strategies, for example, shared risk strategies or agreements. This has allowed us to decrease our spending, and now the fund, for some years the fund has been working on implementing programs where payment is made through modules and variable payments. And finally, by law, infertility treatment can be included as co-payments within the fund when couples are treated. So a long time at the beginning, we had payments per act in the highly specialized medicine institutions. Now we have a system of payments which is more efficient for the fund, and now the fund better manages public monies. Source of funds, the budget for 2018, $250 million. As you can clearly see, over 80% comes from the National Health Fund. There is a 6% that comes from out-of-pocket expenses, 10% from general revenues, and a 2% coming from lottery games and co-payments for infertility treatments. Regarding the evolution of income, in blue we have the prepaid payments as different groups of people have entered the system. This rate has increased, and the and the payment of specific medical acts has decreased for users and through the Ministry of Economy. Expenditure, 80% is invested in medical acts or procedures conducted in highly specialized institutions, and 16% is invested in expensive medication. This is division of medical acts: 40% heart procedures, 30% for dialysis, and around 12% for trauma medicine, and a smaller distribution among the different types of services funded. Regarding medications, approximately 50% is invested in cancer medications and around 16% in rheumatologic diseases. This is distribution of income. There is an increase in the investment of the fund in medical acts, and there is a decrease in expenditure on medications. This doesn't really mean that there is a lower coverage of the medications area. Rather, it shows that new negotiation and agreement methods with the industry are more efficient. We have been able, therefore, to reduce the spending at the fund, but it has also allowed us to include more patients, as you can see on the chart on the left. And on the right, you have the spending on the medications. This is a different way to reflect the same thing. There has been an increase in the coverage of number of patients and new treatments, and a decrease in spending, so investment has been more efficient. In 2004, when the fund began to invest in medications, it invested 1% of its spending. Now it reaches 16%. And this shows once again that this is the result of the efficient negotiation, whereby the price of medications has been below the IPC. Actually, some prices have gone down, so this has allowed us to invest in new treatments. Something that we should also highlight has to do with the future, where the coverage of chronic pathologies such as rheumatoid diseases, we need to anticipate an increase in this kind of pathology. We will now focus on the second section of the presentation. We would like to point out some aspects the fund has been working on. They have to do with quality and also with the economic sustainability of the institution. As I was saying before, in the first stage, the fund was in a risk situation. There were problems with results. As I was saying, for almost 2 decades, we didn't really know what we were investing public monies in, which the results of the services were. There was an excessive demand, maybe demand induction as well, and probably excessive spending. And here we could have implemented a restrictive strategy with less coverage or with limited coverage, which was not following evidence-based medicine. But actually, the institution chose a different strategy to evaluate, to optimize quality by considering efficacy and clinical results. And this had an impact on results. Not only a clinical impact, let's say, it also had a result on the financial outcome. The fund implemented a number of strategies, as I was saying before, by having priority models, by developing different impact plans. This allows us to work with coverage throughout the fund. We implemented a few tools such as clinical meetings in order to authorize certain medications or techniques to be used for some patients in particular, and with different negotiation strategies with the industry. The fund also worked on the quality of benefits by auditing the structure and process of IMAES. We also monitored real-life data. We implemented prevention programs. This fell in line with national health policies, yes, and also it was considered a risk management strategy by the fund. And we also work with chronic diseases because if they are not addressed correctly, they entail new procedures to solve them. Also, a training section focused on patients and the clinical work. We will now go into further detail around these two topics. The fund implemented different strategies that had to do with measuring quality. It has already been said here today that it's important to measure the quality of healthcare, and it's also very difficult to do so. So this remains a major challenge nowadays. Within the evaluation and follow-up program of IMAES, here we can have some background information. The fund and its connection with these institutions, the fund has always promoted quality through courses, this program, etc. In 2003, the executive branch issued a decree saying that the fund, in cooperation with the National Health Authority and the participation of the institutions, they set the different indicators for different areas. In 2004, there were technical visits at the dialysis centers and at other institutions. In 2012, the evaluation and follow-up standards to improve the quality of the institutions is the tool we use nowadays, and we're actually updating the book this year.
Objectives of the program are basically focused on training, strengthening of the health staff. They don't have inspection purpose, but to promotion of the processes that focus on improvement and sustainability of quality. And no doubt, and the minister today mentioned this issue, it has the possibility of orienting institutions towards future certification or accreditation. The IMAES are visited by a multidisciplinary team that is made up of medical staff, resident doctors, and an engineer in the framework of the agreement with the School of Engineering for evaluation and control of the medical teams. This is a methodology of work that ends with the preparation of minutes in agreement with the institution's authorities, and a new visit and follow-up is scheduled. The indicators are related to all these ideas: the physical building, the equipment, documents, and the clinical medical history, with the objective of improving quality processes and safety of the patients. This is the instrument that we use. This is published in the webpage, and we are updating it this year. It establishes the quality standards, and what is important is that they have been agreed with the different IMAES through the management contracts, and they include in the provisions requirements that are included in most of the models of quality, current quality models, and some of the aspects that are considered is informed consent, system of information, training, standards, protocols, and others. These are the 5 criteria used. The first one focuses on the proactive attitude of the institution, the second of the institutions, the second about the management and the supervision of IMAE. The third one is the organization of timely access to care. Fourth, about the environment of attention of care. And the fifth one is related to the training, staff training. Each standard, each quality criteria. I will not mention each one of them, but it has its own standards and a checklist that allows ensuring that these quality standards are being achieved. And then there is it also establishes a degree of full compliance, if it is fulfilled or not, or if it is under processing. All of these techniques were audited in 2018. It's over 90 centers that were audited. And without going deeper into that, this is an evaluation of this program. I would like to point out some aspects because this program has been evaluated and it showed very auspicious results, very significant beneficial results. This chart shows the different standards, the different EMIs. This is an evaluation of hematological institutions, and each cell shows a percentage of compliance with the standard, and it's colored from red to green, the percentile of the EMIs, considering the total result of all the EMIs. And I just ask you to see how this is colored, this chart is colored, and compare it with this one that is a visit 6 months later, where practically for almost the entirety of the standards and the EMIs, there was a compliance and improvement in most of the quality standards that was really significant. Nowadays, the fund is focused on improving the methodology of evaluation of the EMIs through the development of composite indicators. Simple indicators are a valuable tool, an auxiliary tool in the evaluation of quality, but they also have their limitations when you try to evaluate very complex processes, multidimensional processes. So nowadays, from different environments, we are working in the building composite indicators that will allow us to have a single summary measurement through the mathematical aggregation of simple indicators. And one example is, for example, the Human Development Index that adds different indicators: alphabetization, GDP per capita, education, and from the health environment, many countries are focused on developing these indicators. They are very useful for following up through time, and they are useful for sanitary authorities, for decision making, and they will have an important impact on the health system as a whole. And this is information that can be easily understood, and that in general the general public will be able to get to know in the most suitable manner. This is what we have been working on, and what we propose for this year were, no doubt, it including the EMI experts in the discussion of the conceptual framework of simple indicators. And I will end with showing some examples of another area of the fund that is connected to quality, and that's the assessment unit that executes and carries out different evaluations funded by the fund. The web page shows most of the evaluations, and I'm just showing some of them here. And I would like to show you 3 examples that show very clearly how these evaluations are focused on evaluating quality, and they allow sanitary health authorities to make decisions. The fund funds breast cancer treatment, and this is an international paper that shows in 5 years a survival of around 87%. This is the evaluation made with real life data of the National Resource Fund that shows a similar survival rate as in the international studies of around 87%. This is not only indicates the effectiveness of the treatment, but indirectly it also shows the quality of the total healthcare process for breast cancer patients that involves healthcare teams and providers. The fund also funds kidney cancer treatment, And this is an international paper that compared two medicines covered under the fund, pasopanib and sunitinib, and concerning different aspects. These are the data of the price of the treatments with these two medicines, and you can clearly see the difference. That is practically pasopanib has a monthly cost that is 7 times smaller than sunitinib. In the fund's evaluation unit, we evaluated with real-life data the survival rate of both medicines and survival without progressions, and the results were similar to those in the international paper. There were no significant differences concerning these outcomes, and there were no differences concerning the safety profile of both medicines. So this allowed the modification of the coverage regulations based on these studies and economic arguments that substituted the possibility of choosing both medicines first line for the possibility of choosing pasopanib unless there were, of course, any counter indications against its use. This is a study that's still being processed and discussed, but that also shows elements sustaining the fund's policy of the use of generic medicines. The fund has had a very long history with the treatment of leukemia, and this study showed that the survival rates were similar as the international studies, but it also showed that there were no significant differences concerning the results using different brands of this medicine. This is also available on the web page, the result of the evaluations by IMAE, and these are results of dialysis, and the second one of another type of procedure that shows when there are significant differences. And I will have to point out that for us it is an enormous difficulty, just as my colleague mentioned, about the possibility of reporting results in an easy and understandable manner for the general audience. And this is an aspect that the fund has to work on to make this information more accessible from the single database that is very large of the fund. This shows this distribution per provider and per province. And finally, we can conclude, I think, that through all these tools that we have shown it has been possible for the fund to lower the number of inadequate prescriptions and improve the quality and safety of care, reach economic sustainability that was threatened over 20 years ago, and improve and increase the services that are funded by the fund. Thank you very much.
Dr.
Cambogi has really been very enriching, really, to hear all the different health systems of Uruguay, of Argentina, of Belgium, and we will later make comments. And now, Dr. Federico Preve, the representative of the Sindicato Médico del Uruguay, will take the floor. Good morning, and thank you. First of all, I would like to thank the organizers on behalf of the Medical Union of Uruguay, and I'm speaking on behalf of the chairman, who is currently in Chile, so I'm representing him and the Sindicato Médico del Uruguay. So, As the people before me have made it easier to access some topics, I will try to be as brief as possible. What really brings us here today is the quality of care in the entire health system. And as health systems are dynamic and the historical processes and the contexts are really important, things have to start somehow, and so we should mention some of the background, and I will give the perspective from the Sindicato Médico del Uruguay, the Doctors Union of Uruguay, which will continue to be an important player in every aspect related to the health system, regardless of its explicit trade union role. The Solis meetings that were carried out before 2006 prepared for important instances that were medical conventions from the 8th and the 9th. From the 8th convention, there were some ideas that were fundamental for the health reform that was carried out in our country starting in 2006, and the Sindicato Médico and the medical unions have been a fundamental aspect in contributing to this. But focusing on quality, which is our topic today, the 9th convention had as a theme the quality of care, and 4 task forces were formed that worked for months. In 2014, over 3,000 doctors from different organizations. In group number 1, they worked about the improvement of the model in the practice in healthcare. And group number 2, strategies of training for human resources, especially concerning medical residences and recertification, which has not yet become available in our country, but that will eventually become a reality. If we talk about quality of care, medical recertification is a must. In group number 3, we worked on the work conditions and the reform of medical work. And in group number 4, worked on participation and performance and results of medical care. Out of the 9th convention in 2014, I will choose some of the core points that have to do with the improvement in the care, that have to do with the policies of reference centers, that have to do with the reform of medical work, also the system of health accreditation and indicators. We saw the excellent development of the National Resource Fund in the last few years concerning this topic, but for the rest of the system, we still have pending issues, especially for healthcare indicators. And there's a proposal of a system for all the healthcare providers, an agency of evaluation of technologies and medicines, not only of high-priced medicines, but also and highly specialized technologies, but an agency that assesses all the technologies in terms of costs, in order to foster or decrease the incorporation of some technologies. First of all, to have a clear view of the price concerning GDPs and per capitas. After the 9th medical convention, within the Sindicato Médico, the medical trade union, there's a project of trauma and medical emergency national system in an attempt to articulate all the players that are present in our country in a coordinated and systematic form to reduce some of the problems. And I would like to stop here because this is an important point. The rate of accidents in our country has grown a lot, and mortality and disability in young people under 40 is not just a pandemic, but it has growing at the national level. But we propose a system of on a system for about trauma and medical emergency, and we will speak about these proposals. The first two, the reference centers and the reform of medical work, are two proposals that have been developed with different levels of achievement. And the other proposals is accreditation system, a national accreditation program, the Agency of Evaluation of Technologies, and the trauma and medical emergency national systems have some written projects, bills, or decrees, projected decrees to make them possible. And we will speak about each one of them. The reference centers that were an idea that arose in the 9th Convention that are connected, as it was explained in the first presentation, on how to leverage the volume effect of some lower prevalence diseases and how to avoid duplication of structures and human resources and material resources. And there is a bill already prepared. There is a law that has been approved. And last month it was regulated, and we will speak very briefly about it. Concerning the concentration of professional expertise and technological and material resources that are working under the IMAES nowadays, but there are a lot of other reference centers that are actually working as such, but without any control, without a legal framework. Some points that do not agree with the project that was sent from the Sindicato Médico that has differences with the law that was approved have to do with two different nuances. And one is that the Sindicato Médico project presented to the Health Ministry and also in parliamentary commissions implied direct funding through a percentage or a quota of the FONASA fee that would go from the provider to the reference centers without the intermediation of the resource fund. The mediation of the fund has three ways of funding. The ones that is covered by the PS, but will concentrate it in the resource high technique center. Those services that are already funded by the National Resource Fund will change their legal framework, and some of them may work under IMAE and other under reference centers and will be funded by the fund itself. And the third point is those services that are not being funded currently, and the fund will make an analysis of the cost effectiveness and impact in order to determine whether that reference centers is required or not, or how to provide this service in Uruguay. Another central point for us that is how those centers work, which is what I will mention now, that has to do with the reform of medical work and high dedication positions. And it sounds strange to say it, but when a professional concentrates its work in a single center, especially if it's a reference center with a pathology that is low prevalence, where they have to do teaching and research, and they have to try to improve the quality of the service, they should work with a high schedule concentration, and they should work exclusively for this center. It's important to move ahead in paying healthcare payment and not medical act payment. This is one of the aspects that had a differential payment, and the law gives a national coverage, mandatory derivation to the reference centers for that pathology, scope of the pathology that will depend on the provider, and the approval of procedures of reference and counter-reference. They will be appointed by the Ministry of Health, and there will be public calls through mechanisms that ensure public and private or mixed entities equality of opportunities to be reference centers for some pathologies, and there will be a commission for advisory on centers and services of reference, and it will be evaluated by the Ministry of Health, and it's made up of 2 members of the Ministry of Health, of the National Resource Funds, and a member of the University of the Republic, and there will be records that will be created to provide indicators such as the ones provided for the IMAES, and there will be economical penalties for public or private providers that do not comply with the law, because it is these reference centers is where the pathology would be treated at international levels, and human resources training has a mandatory condition for reference centers to try to get those reference centers, to try to avoid that those reference centers are not a concentration of the knowledge of a low-frequency pathology by some professionals and qualified people, and they become power centers, but that there is sustainability and the possibility of continuous training.
Regulation. It's been in effect for just a month. There will be new reference centers and a commission appointed this year. Initially, there are already several reference centers, but not within this legal framework. The ministry might actually work in this regard, and reference centers will be included gradually, and their inclusion will be analyzed as well. Their inclusion will last for 5 years, and this inclusion may be renewed after there is ongoing assessment of the standards and indicators regarding the resolution of pathologies. Given the number of inhabitants we have and the scale, it is very likely that some pathologies will need to be referred to international pathology centers. This should actually work within the Commission, because there should be places where quality standards are adhered to. The ministry can evaluate quality through indicators, and they will be comparing them to international standards. The second section of the talk, it has to do with the reform of the work system of physicians. This started in 2012 through several wage councils and agreements held between workers and the executive branch. There has been a major debate within the physicians community as well. We believe it is essential in order to improve the quality of care. There are high dedication positions in the mutual centers between 40 to 48 hours for standard specialties, above that for other specialties. This is not an outsourced or freelance work. There is an employee relationship. Physicians are not fully devoted to a specific institution, but the idea is that they become loyal. They fulfill different roles, so they work in different areas or in the areas agreed on by the physician and the health provider. This means that they work in surgeries, in operating theaters, they visit patients in hospitals. They have also to attend weekly training sessions, which is very important regarding lifelong training for physicians. This is very important to ensure the quality of physicians. Also, the idea is to have fewer asymmetries within the group of physicians. this reform that has been developed for some time now for medical staff should also be applied to all the health human resources. Also, we need the same wages. There is a modification of the Act payment, and the payment now responds to productivity. There should be, most agreements include a 60 to 70% of the wages, and the payment on account of productivity is not eliminated, but rather in a way it is rationalized and it is structured in a different way, because and then the fixed wages are higher than the other types of payments. There are also activities that have to do with other issues, with education, etc. They correspond to different departments in the hospital. They have to do with services in order to improve care processes. And if this works, it really improves health results. Physicians need to have the specific degree for the specialty. There's a limit to the hours they can work on a row. The limit is now 16 hours, and this improves the safety of the physician and of the patient. It also rationalizes the different regimes under which physicians work. There is a fixed remuneration system, fixed 75%, variable 25%. Full dedication positions are now 10% of the medical doctors working, now 1,000 in the mutuals system and over 300 in the national health system. This is a reform process, and we are living now a transition process. Hopefully in the next few years it will consolidate, and at some point the whole set of physicians in the country will work under this regime. Here you can see the figures I was telling you about. These are conditions which are essential in order to improve the quality of life of physicians and to improve the quality of care provided to the population. There are some studies that analyze the economic impact, and also they have followed up on the results obtained by patients and other types of data that have to do with this regime. I will now mention some of the proposals stemming from the Medical Convention in order to improve the quality of care. These have not yet been included in the health system. One has to do with the health accreditation of health providers and throughout the system. Our system is special because it is based on the competition and complementarity of providers. When there is mobility, we haven't had mobility for 2 years, okay. And from the union, actually, we defend the permanent mobility of users, maybe with some limitations, but it shouldn't even be regulated once a year. This mobility should be based on, as it was said earlier in the morning, it should be based on care indicators. There are some economic indicators that are important because health payments are very important in a specific band of people. But we should actually focus on care indicators that have to do with intra-hospital infection rates, average number of days in the emergency unit, etc. All these indicators should be essential in order to for health services to become accredited. We should have a national accreditation system based on indicators, and this should run throughout our health system. The system should have indicators about the number and type of equipment, also facilities, investment, operation of diagnostic and therapeutic services, also regarding the work safety of the staff, the systems to distribute medical inputs, also coordination at a national level regarding all this information, maintenance and renewal of equipment, training of human resources. One of the key elements that I'm not mentioning today has to do with the residency law. We need to also have providers include residents, and we need them to train human resources as well, because this is a quality indicator. Those providers that do have have human resources being trained as interns or residents, well, this improves their quality of care. Gradually, these residents are also included in private providers. It's actually La Española is the private provider that has the highest number of residents after the School of Medicine, the Hospital de Clínicas, and the National Health System. This really speaks volumes about the quality of the training of human resources, because it also talks about the knowledge of all the professionals that work there. Also indicators regarding guidelines or standards or medical protocols. All these indicators should be accredited, and providers should be included in a single accreditation system in the country. Another key element, we need an agency that evaluates technologies and medications. This is a useful tool to observe the efficiency of spending regarding the efficacy of treatment. It should have apparent and clear aims and mechanisms. We need assessment mechanisms, and this agency should make recommendations to the government, because the government should decide on this. And we believe, and the Convention also believes, that this agency should be technically independent from the institution that sets the spending. This is arguable in many places in the world. This is not the case. It is the agency itself that determines the spending on technological resources, especially regarding highly specialized medications and also high-cost medications. But there are other countries there are some role models. Some countries have recommendations, let's say, and there is another political stakeholder that defines the type of cost-effectiveness analysis, and they also decide which benefits will be included or not, depending on the political decision based clearly on the technical regulation provided by an agency. This also applies to other types of benefits. We would recommend that we have a single system for highly specialized medicine and for the rest of the comprehensive health system. It also regulates the system, and as it is independent, it provides us with further transparency, because it makes recommendations, and there is an independent political stakeholder that makes the decisions. It would be the Ministry of Public Health in this case. The ministry will take decisions based on the recommendations of the agency. This improves the quality of care. When the agency is independent, this independence is the major issue in this case. Bit of law regarding the national system of trauma and medical emergency. This is a key element nowadays. I would like to talk about the Easter week. There were several accidents and 15 people died according to our data. Almost all of them died at the place of the accident and at the time of the accident. According to the most recent figures of the road authority, we have been having serious problems, especially in the rural areas and in national highways regarding mortality rates at the place of the accident. We believe it is essential to regulate the pre-hospital care, especially at this time of when the trauma occurs, which is very relevant in all the country. The project was developed by UNACEF and the emergency faculty at the Hospital de Clínicas. The idea is to have a law that regulates all the already existing resources, over 50 emergency mobile units in the country, private and public. The idea is to coordinate their work with aircrafts, the 2 or 3 aircrafts we have that can transfer patients. The system would be public. Why? Because it would provide care to the whole population. It would include public and private stakeholders. Its aims would be to prevent, care for, and rehabilitate this type of patients. The idea is to work with different social stakeholders by coordinating the human resources and also tangible resources we already have in the country and which we are using but incorrectly. Aims to create protocols to handle care in a universal way so that all users can be treated at this time of emergency, especially regarding transfer to centers, transfer to places where places that have been technically categorized. If you do not know this, when there is a double transfer, then a person has twice the chances of dying. If the person is transferred to a categorized center and defined as specific to treat that patient in that trauma situation, and if the patient is transferred there, for instance, someone who has a serious head injury, if the person is not transferred to a UIC unit, or they're not transferred to the specific surgery department, then they have a higher chance of dying. The system has also a record, as does UNACEF. The idea is to improve policies regarding care and rehabilitation, also risk management guidelines and training plans for human resources for time-dependent pathologies. As we know, we need prevention programs because trauma pathologies begin when the accidents haven't happened yet. The zero alcohol policy is a major example of this. And we support it from the Union because it has radically decreased mortality rates in the previous years. This will also have a quality control program. Well, these were the elements I wanted to mention. Okay, I've been shown the yellow card and I've just finished. So these were the 5 elements I wanted to mention regarding quality of care. Thank you.
Bueno, muchas gracias, doctor Previo. Y terminando.
And to end the second panel about a topic that brings us here, we will hear from Dr. Julio Martínez, who is the General Manager of the Asociación Española of Mutual Care of Uruguay, and from 2001 to 2010, he was very strongly related to the UMU, and he was a member of UMU. Thank you very much, Maria Jose. First of all, I don't know if I should say good morning or good afternoon if we are going to follow the time or the lunch. I would like to thank AMA for accepting to hold this conference in Uruguay about measurement of quality in healthcare and funding. And last year we thought this idea of discussing about the topic in Latin America and with experts such as Matthias, whom he had heard in Estonia. By now, you know that a study carried out in Israel about freedoms. By now, up until now, judges gave a high level of fewer freedom because they had hypoglycemia. So in your case, you will not be very tolerant because my glycemia is always high, so I don't have any problem with insulin, and I don't have the problem of the judges in Israel that would not pardon so many people. So because we have visitors from Argentina and Colombia and Paraguay, Belgium and Brazil, the first thing that I would like to say very quickly is to speak about the characteristics of our integrated health system so that we can talk about quality in that framework. Our system provides integrated care to all the inhabitants of the country. It has a primary health care strategy at the spaces. It carries out prevention, promotion, diagnosis, medical and surgical treatment, rehabilitation, and palliative care. And it has all the three levels of care, both in ambulatory and hospitalization cases. And it's a mixed system with private and public providers. This is funded by a national health insurance, which is funded by FONASA, formed with the contributions of workers and employers, and the remaining funds are provided by the state. This fund is managed by the Banco de Previsión Social, and we thank the presence of the representative who makes sure that the providers always can collect, because they manage the fund without touching it, because when the health reform was being discussed, we were coming from a crisis, and the health system collapsed during that crisis, and it was sustained thanks to the people who were in the welfare system, because the Banco de Previsión Social paid every month. And so the money, and this is in the IDB that had intervened the Ministry of Economy, they said the money was vacuumed by the central bank, and when the providers discussed, we said that we didn't want the health monies to be mixed with the general revenues, and the Banco de Previsión Social, the welfare bank, has always been a very good payer, and that's why that fund was kept there. And because Elvira, the representative, is here, we would like to make that recognition to the National Health Fund that funds a large percentage of the capitations of the patients. So the National Health Insurance pays a quota that has two components: a capitation that is adjusted by risk, measured according to age and gender. Higher capita is the highest is male under 1 year, and then follows a male over 65, etc. And it adds a premium for the fulfillment of healthcare goals. These premiums are already connected with healthcare quality, because the premium is paid if you reach a certain percentage of compliance. The goal 1, which is one of the oldest, covers the health of children and women. I will not give all the details, but it measures that all the health control checkups are carried out for children, controls of development and growth, of ophthalmological checkups. In the case of women, the early checkups of the pregnant women, and you make sure that all the required controls are carried out. And in addition to this, the program Gender and Generations in the follow-up of domestic violence in different aspects. And this goal is paid. It's an important amount of money for the institutions when it's not reached. For example, women that are checked in the first month of pregnancy, percentage of, if they have 99% and they get 98%, they will not be paid for this goal. Goal 2 used to be how many people in each chose the reference doctor. And now goal 2 is related to the achievement of some health goals at the national level that are connected to non-communicable diseases. Not all of them, but most of them are very connected, especially chronic illnesses. And so they established 4 indicators to control this goal. 2 national indicators that are common to all the institutions, that is the reduction of high blood pressure complications and overweight. And one that we have chosen about overweight and obesity, which I have problems with, and the other is the incidence of suicides. And there used to be an older adult, senior citizen goal that has been suppressed. And goal 4 is a reform of the model of human resources related to high dedication positions that are funded by a goal. And the last one is related to the training of health care staff that pays a premium for courses to be held. So we see the way of funding has an area that is connected to quality, that is the healthcare goals. And this means processes and results. Most of the goals and the big discussion is always related to results. The quality was not distant from health reform, because we were saying that for over 11 years, Uruguay has had a process of reform of the health system that started with a budget law in 2005 that has more program aspects, and in Law 18211 that created the integrated system that started in January of 2008. And as you see, the word quality is in several provisions, sometimes saying that better quality has to be provided, and in some other cases, the quality of healthcare. And the budget law that I was mentioning, 17930 of 2005, already mentioned in one of its program articles that it should reach integrated and quality satisfactory level of healthcare. The quality of healthcare was considered as also as quality of health. So 2 elements. And another thing that has been a bit forgotten, that in all these discussions, is law of the integrated health system was discussed for 2 years in a council that was made up of all the players. The UMU was there. There were 4 commissions. We always had a commission, sometimes with Dr. Hinz, would go for Casa de Galicia, just to make sure I didn't misbehave. And if out of that law and the discussion, we came out with this article 45 that establishes that the government has to establish mandatory services and the components of this basket, and that only that basket will be covered. But it says something in Miami when I was preparing this presentation, in Easter week, of course, the last provision of the law, that I was really surprised by it. I had to change the presentation because I had even forgotten that this article existed. And it says that the regulation of the law should establish quality indicator for processes and results according to which the National Health Board will audit the quality of care that is offered in order to authorize the health quota payment to the providers. And this is not done. We have discussed it many times. It's very difficult to measure quality. And the other day, when I heard it in Estonia and the Germans were speaking about how they measured the quality, but in Uruguay, people say that it's not possible, but it's an excuse because it's good for some and not for others, because we pay all the capita to others. But here it says the opposite, that the basket of services will have to have process and result indicators. And there are lots of philosophical aspects that imply that it's something that is not applied, but I would like to say that for me, the law has to be fulfilled in its entirety. That says that the norms and law are not unconditional, and they have to be fulfilled in order to progress with change. And the idea is that eventually we will reach the point where quality indicators are established so that when the National Health Board authorizes a payment, they also audit. So it's incredible that we had completely forgotten about this. And I was a member of HUNASA for 2 years, and I never thought of asking for this to be fulfilled. But the health system is being consolidated, and it takes time. But this instrument of connecting the funding of quality as it had been provided by the law, that was promoted by the same government and the providers, starts to be applied. But then one of the big problems is, what is quality? Yesterday, I was trying to finish this with the holiday and my flight trip. I called some doctors who work in quality and some of the nurses, and I asked them, what is quality? This, that, objective, subjective, part of a process. So I left them alone, and I told them, this is my problem. I have a problem that St. Augustine had with time. If nobody asks me, I know it. But if I want to explain it to somebody asking, I can't. So everybody knows what quality is, but when we try to define it, we find it very difficult. So I used the famous dictionary of the Real Academia that has some definitions referred to what is considered intrinsic quality, objective quality. It also depends on the point of view. This is what people were telling me yesterday, but it depends on the patient's point of view, the provider's point of view, of the government's point of view. I think Dr. Danza was there, who was in the emergency, and he said, what is the quality that the patient wants? They made 25 exams, they did tomographs and all types of imaging tests, and he was happy. But all he needed was a magnetic resonance and one prick So was it the quality of the provider or the quality established by the guidelines or the protocol or the government? So this is completely relative, and there are classic definitions also, and I will not analyze them because of the time and the hypoglycemia that you have. But there is a WHO and Donavedian that should be the basis for our daily work. So as we were looking for the different theories, I faced the dilemma of the School of Athens, where Plato focuses on the sky and Socrates on Aristotle's on land, on the earth. So let's work on the practice of quality without discussing so much how we should focus it and what should be the theory. Otherwise, we will end up not applying the provision about funding and quality. So how should we do it? So we have real substantial quality, objective and subjective. What should we do? We should finish with what I saw in Estonia, and taking into account that law is full of antinomies. Health is full of antinomies, but also law. So health is a merchandise. It's a right, but it's also merchandise. But it is sold in the market. Otherwise, we wouldn't have private insurance or aesthetic surgery, plastic surgery clinics. So the system is mixed, and it says that we should be complementary. But every February we compete very seriously for membership. The system has a contradiction between equality and freedom that is typical of every government. Nobody would think in Uruguay that it's possible to have the norms of Europe of how to go to see a doctor. For example, in Estonia, you're always seen by a primary care specialist. And when you go to the specialist, you don't have a freedom to choose. You go to this National Central of Authorizations. And that agency will say whether it authorizes or not the transfer to the specialist and to which specialist. And if they're in a hurry, they will authorize a video consultation because it might take 60 days to see the selected specialist. So in Galicia, in the Sergas, they have to go to primary level, and then they will go to the specialist that they are told they should go. And the same thing in Andalusia or in Valencia community. So we have a system that is filled with freedom because it has freedom of choice, maybe every 3, 6 years or 2 months, but they have freedom to choose, and also within the institution they can choose anything. And then there is subjective and objective quality. I was saying that in the history, it was the first assembly of AIM, and I went because I liked the topic. And also went to Estonia because it's close to Russia. But I said that I was in Moscow, that I was in the World Cup because La Española was sponsoring. It was really funny. La Española was sponsoring the national team, and we had 6 tickets for all the matches. And a group who was not with the majority of the trade union, and we are in the photo with Maria Alvarez and Ajoya, and they say I had taken the dollars of the salaries to Russia, but actually we were toasting the fact that we had decided not to fire an employee. And they said, you have to toast because you saved this lazy person. But they thought that instead we had taken the dollars of the bonus salary that we had taken to Russia.
We had some delay problems with the bank's transfer. At the Committee of European Affairs, we observed several interesting things regarding the quantification of quality, how you can relate quality and funding, how to use data analysis to measure quality, how to get patients to participate in its definition, and how to address the transparency of information on quality. So I was thinking, well, they were talking amongst themselves, and I was thinking, well, but these indicators that they're showing are very clear. We use them every day. They are present in most of the data we have to report monthly to SINADI, and we have other indicators as well. So they haven't really reinvented the wheel in Europe. They have systematized the indicators we use every day, and it's great, and we've been trying to do this for 10 years. So when I got here, I wanted to show them how it can be done. So for the next there was a debate on capitations 2 years ago, and the idea, someone thought about reducing the amount of the capitation. That was a bit difficult debate, but I told them that they needed to determine the quality of the care.
Entonces, como consecuencia, no bajaron las cápitas.
As a consequence, they didn't decrease capitations.
En el Consejo Directivo de la Española, que inmediatamente...
When I arrived at the board of the Española, I said that within the institution we needed to apply the quality indicators, those that we work with every day, the ones they use in Europe as well, and we can show them that we actually can work with this and that it can be done. So the board took this issue on as an institutional matter, and it created a care quality institutional committee at the board. Jorge Basso was saying that it's important to involve staff and users. Well, actually, the users are in charge of health mutuals. We know this. We shouldn't be talking about this opposition managing staff and users. That's basic. In the case of La Española and Casa de Galicia, workers are also part of the steering committees. This committee is formed by 4 members of the steering board, Efraín Manicia and Nicolás Díaz, chosen by the members. He's over there. He hasn't gone out to lunch. 1 representative of the medical staff, Dr. Miguel Casajian, and 1 representative of non-medical staff, Mrs. Maria Alvarez. Also, the technical director, Grandal, the under-manager of the Department of Nursing Services, Janina Costa, Chief of Department of Planning and Care Control, Dr. Silvia Molins, President of the Infection Committee, Dr. Lucia Alonso, Pharmacologist, Dr. Viana Dominguez, and Doctor in charge of Care Targets, Dr. Miguel Perez. I hadn't realized what Dr. Jorge Basso had said, but actually they pay for the care the same cost of parking space. I hadn't realized this. There is a problem with costs. Many times I don't know, some countries compare the cost of things to the cost of a hamburger in Chile, the States, Estonia, whatever. And I hadn't considered that. We cost the same as it costs to park your car for a month. So what is this about? We need to show people that it's possible to measure quality with parameters and indicators we use daily. But this requires work, effort, systematization, commitment, and cultural changes. It took us 6 months to get the first measurements to be implemented. And of course, we have this Congress, and we said that they should be ready before the Congress. We shouldn't just, boost the topic and then have nothing to work on. But we do have some results. We need to further consolidate the achievements as well. We do not have much time, and I will stick to the summarized version of my presentation. What are we using to measure quality? Which indicators at this first stage? First, loss of patients. As you know, there was under recording, now there is better recording. We have improved the sorry, it wasn't loss of patients, it was patients falling, it was falls. And now we are well below the international median. We now have a new program to prevent mistakes when dispensing medications to hospitalized patients. Measurements are made from a baseline, and now we have a procedure whereby these dispensation mistakes are analyzed. We worked with the idea of how the institution in a specific document has determined how to study aircraft mistakes. We have a similar system now, and the aim is to determine the probable causes behind these mistakes in order to prevent future mistakes. And the idea is not to necessarily penalize the guilty staff. The main aim of this system is to prevent future mistakes. In the past, if someone made a mistake, the person would be suspended for 5 days. If it was too serious, 15. If it was really, really serious, they would be fired. When we consider patient safety and quality of care, we need to focus on procedures that need to be proven, so much so that accident research institutions cannot really provide the necessary proof, because accidents and incidents are prevented when you have these free studies that determine the immediate and endemic causes of the system, because many times when there is an error of dispensation, it's not just the nurse's mistake, or just a mistake made by the person in charge of the pharmacy. It might be a mistake within the institution itself. Another element is the consumption of antibiotics during hospitalization. We are now streamlining this indicator. We have harder indicators in order to rationally use antibiotics during hospitalization. There is an item missing here. I think I made a change to this presentation. It has to do with measuring hospital infections, and these measurements have also been included in the work of this committee I was mentioning before. The president of the committee is also part of the other institutional quality committee, and we have followed up on some of these infections. And we have also worked on the early report of specific diseases. We will be starting with 3 of them for this section. Lucia, if I remember well, tuberculosis, also smallpox and the flu. So Lucia works at La Española. She's the best epidemiologist in the country, and she was almost abducted by the WHO, but she wasn't. We also need indicators to monitor hand hygiene. I really focused on this because it entails a $1 million investment, but we will establish a system which we have seen in some countries such as Argentina. In this system, each member of staff enters a room. When they do this, an alarm goes off, and the person should wash their hands. And then the alarm is disconnected. That system is connected to the software. The software tells us how many people entered the room, who washed their hands, who didn't. Some people just go into the room and then leave the room just not to wash their hands. And it's really worried the high number of hospital infections we have on account of poor hand hygiene, and this has an impact on the health of patients and on the cost of treatments. So this is a major investment, but actually we will balance it off with the cost of antibiotics. We do have debates or discussions on this with really top specialists, but when we tell them that they need to wash their hands, they don't like it. Now we will have a system whereby the alarm will go off and the supporting software as well. We should reach the 100%. Matthias said that 100% is not reached in Europe, but maybe we will be able to do this. We will be measuring hand hygiene. They can also use gel alcohol. Well, as you know, the Clostridium difficile, which is very difficult to combat, is not eliminated with alcohol. We have been measuring these elements for some time. For instance, patients falling since 2012, and others are more recent, but they're all working. So thank you to the whole staff. Regarding subjective quality, we saw at Tassin that they're using different surveys for patients. These are anonymous, easy surveys that include 5 or 6 questions. They're not really long. When the patient is discharged, they are given the survey, they fill it in anonymously, and they place it inside a box. We used to have satisfaction surveys, well, twice a year. Besides, after the hospitalization, also with outpatient care patients, etc. We've been working with Factum since 2010. We will be measuring this effect through these surveys as well, regarding what is felt when the patient is discharged and after 6 months. So these are the first indicators with which we measure quality in elements which are relatively easy or not so complex or esoteric as may seem, and later on they may be connected with funding. The committee is working on other elements as well. One of them is quite universal. It has to do with readmitting patients. Also, prior informed consent before surgeries. This is very important. It should be implemented, but we haven't quite made it yet. Also, the electronic clinical record. This is already implemented in the outpatient area. Also, the surgery checklist implementation. It has been implemented for some time, and it has kind of worked. I do have an anecdote. My appendix was removed 7 years ago. Ana Rodriguez was with a checklist. Someone mentioned the informed consent, and someone said, "Okay, Julio, can you sign this, please?" I was already lying on the operating theater, and I said, "Did I draft this document?" And they said yes. And then I said, "Okay, then I'll sign it." So Anna was going through the checklist, and she found that we were missing the informed consent. As we have now gone from paper to software, we haven't quite implemented the full surgery checklist system in operating theaters. We still needed to solve the YHAV problems we had there and other issues. I believe that in about a month's time or 2 months' time, this will be in operation. Besides administration and dispensation mistakes, we will also measure prescription mistakes and also dispensation of medications in outpatient care. The electronic format has improved all this because we do not need to interpret the doctor's handwriting. And then someone else that is halfway between objective and subjective quality, which is measured in surveys. We did have indicators, but we didn't measure it as a quality indicator. And it has to do with specialties and a scheduling of appointments. We have systematized this. We systematized this 2 years ago with the different medical appointments, so we started to measure this as well. So we decided, okay, I'm missing a slide, but okay, we decided to work as we went along the path. We decided to use regular elements that tend to show important issues regarding the quality of care. And this is what we wanted to share with you today. Thank you.
Dr. Martinez.
Dr. Martinez, I believe that this morning and these presentations have helped us rethink what we do in our daily work, especially regarding what Matthias was saying regarding the importance of what patients or users feel when they need to choose different therapies. Also, this example shown by Dr. Martinez with La Española, which is an example to follow. Just by way of anecdote, in Uruguay, studies have been conducted regarding the quantification of hand washing in neonatal units. And actually, it's physicians who wash their hands the worst. So this is a very important topic. We really do not have more time. If someone has a question for any of the speakers, you're welcome to do so.
Bueno, agradecerles y Beatriz.
Thank you. Beatriz, we will now present our tokens of appreciation. Thank you to the representatives of the AMA, UMU, to the speakers, and to the first roundtable panel too. Here are your presents.
Y muchas gracias por sus presentaciones.
Thank you for your presentations.
Les recordamos que la información de todo el evento.
Please remember that you can find information on the event on YouTube following the name of the Congress. It is all the information is available.
Los invitamos a compartir un lunch en el foyer.
We now invite you to have lunch outside. We will meet again in 2 hours' time with the last panelist of round table 1, Social Protection for Universal Health. Thank you.